Okay, guys, welcome back. This is part 3 of your neuro emergencies. When we're talking about strokes are also called cerebrovascular accidents, or what we call CVAs. This is basically an interruption of blood flow to an area within the brain. So we have some kind of possible clot or some kind of occlusion or plaque buildup or whatever in our vessels that happen to just travel to our head. Think of a stroke as a heart attack in the brain. This can result in a loss of brain function for our patients, all right? And when lacking oxygen, the brain cells stop functioning and die within minutes. It is extremely sensitive to lack of oxygen. And obviously, again, this is also another where time is a factor, okay? We're going to talk about time as a factor later on in this lecture. Problem is that once those brain cells die, there's really not much that can be done in order to get them to grow back. There have been studies out there that suggests that we can grow back neurons in our brain after they have been damaged, but that can take years. It could take a lifetime, and it might not even happen at all. So with the lack of oxygen and the lack of nutrients, the brain cells develop ischemia, just like any other cell on the body would without the lack of oxygen, or with lack of oxygen or nutrients. And because of this, the brain cells will actually stop functioning properly, or just stop, period. Okay? It can take a long time for numerous cells for cell death to actually occur in the brain, but it does start within minutes, and we're talking right around 4 minutes when we actually start killing off some brain cells. We can, with a prompt restoration of blood flow, we can preserve and restore the function to that area. It won't be 100%, but we can help out with some of the function. And unfortunately, we really can't do anything in the field for strokes. It's going to be a lot of comfort care, and this is all the way up to paramedic, guys. Okay, it's going to be a lot of comfort care. It's going to be early recognition, and it's going to be diesel therapy, where we throw this patient in the back of the ambulance and we haul ass to the hospital and give the hospital a heads up before we get there. And the hospitals are really good about having what's known as a stroke alert. EMS will call in a stroke alert, let the physicians know what exactly we are seeing with the patient. And most of the time, specifically here in our area, we're still going to the ER, but as soon as we get to the ER with the patient, we will actually roll the patient to the CT scanner and offload the patient to the CT scanner so that they can do a real quick assessment of what might be going on in the brain. And then there are two different main types of stroke. We have the ischemic stroke, which is basically a block. It could be a clot. Some kind of occlusion is actually cutting off blood flow to one part of the brain. And then we have hemorrhagic, where that vessel might have burst, and now we are actually bleeding in the cranial vault. And the problem with hemorrhagic strokes is that our blood is acidic. And so when that blood is not in our vasculature, specifically in the brain, and that blood starts to touch our actual cerebrum or cerebellum or our brainstem, whenever it starts touching the actual cells around there, it will denaturize the protein structures of those cells and really just cause a massive amount of necrosis, a massive amount of cellular death pretty quick. So the ischemic stroke, again, this is usually where there is occlusion, where there is a block in one of the vessels, and we are not supplying a certain part of the brain with oxygen and nutrients. It is the most common, and it occurs in about 80% of the strokes. It is because of a clot, also known as the thrombus or an embolus. That's basically just could be a plaque clot, it could be a blood clot. We can actually cause this if we insert an IV wrong in a patient. We can see symptoms can range from nothing at all. Maybe we just have slight altermentation. Somebody just happens to be confused and they're usually pretty with it, all the way up to a complete paralysis of the body. And really, again, this is due to the atherosclerosis in the blood vessels, is often the cause. Remember, that's the plaque and the fat buildup in the actual arteries and the vessels walls themselves. Okay, so here's the visual for you. And that atherosclerosis, again, that plaque forms on the inside of the walls of the blood vessels and can obstruct either partial flow or full flow to that area of the brain. And it will eventually lead to a complete occlusion of an artery. And you guys can see where the clot is on the head here, and that whole dark purple spot of the brain is starting to die off. And we really need to make sure that we're able to recognize this, really make sure that we are able to recognize this in our patients quickly, in order to get them to the appropriate care. And time does count, and we're going to talk about that here in a little bit when we get to the assessment. Okay, so when we're actually talking about ischemic strokes, part of the treatment for patients with ischemic strokes is known as thrombolytics. And basically, thrombolytic drugs is the treatment that we use, and this treatment must be initiated within a certain time frame of the actual stroke that's going on. And usually it has to be within less than 3 hours. Okay, so when we're dealing with patients that are suffering from strokes, and we see that possibly that this patient may be having a stroke, we're going to have to utilize our bystanders. Hopefully there's somebody on scene, a family member or a friend of the patient, that can tell us, when was this patient last seen normal? That is a question that the hospital needs to know. When was the patient last seen normal? Okay, for nationwide, it's right around 3 hours. Our area right now, we are doing a study. We are doing a thrombolytic study, and we've been in this study for the past couple years, where we're turning that 3 hour onset window into a 6 hour onset window. So if your patient you guys show up on scene, you guys recognize the stroke symptoms, and the patient's family says he's been like this, kind of getting worse for the last 4 hours. Well, we got 2 hours to get them to the hospital in order for them to be a candidate for thrombolytic therapy. And basically, we can basically use this for what's called large vessel occlusions. And thrombolytics are basically, think of them like as Pac-Man, right? They inject the thrombolytics in you, and these little enzymes kind of travel through your blood system, and they chew up the blood clots. The problem with thrombolytic therapy is they chew up all blood clots, okay? So let's say that we also have a patient that might be having a stroke, but they have a history of bleeding ulcers in their stomach. Well, we can give this medication to help get the clot out of their head, help that enzyme go and actually dissolve the clot that's in their head. But we can also mess up their bleeding ulcers and start a severe abdominal bleed as well. So there's a lot to be considered when patients are being assessed for possible thrombolytic therapy. Really, the take homes that I want you guys to remember for this is that for national registry, it's a 3 hour window of time of onset. And then for our state, it's a 6 hour window because we're involved in this study. So I'll give you another example. Let's say you guys get called early in the morning, and a patient's just not acting right. They seem confused. They seem something's wrong. Their loved one's concerned, and you guys get on scene and you notice the signs and symptoms of a stroke. And you ask whoever the family member is, when was the last time you saw them normal? And they said before they went to sleep last night. Well, then really we don't know what time of onset it was, right? Let's say they went to sleep at 9 o'clock last night, and it's 9 o'clock this morning. Well, that stroke happened within the last 12 hours. Doesn't mean we're not going to take them to the hospital. We still want to rapidly transport to the hospital, but unfortunately, at that time, we may not be within that 3 to 6 hour window, and we just have to tell the receiving end that, look, the last time that this guy was seen normal was 12 hours ago. At which point, they're still going to take them to a CT scanner to look, and they can also decide about thrombolytic therapy after they get the results of the CT scan. So again, a lot of questions in play, a lot of stuff that we have to take into consideration as a medical community for people that are suffering strokes. Your job in EMS is to recognize the symptoms, provide that comfort care, provide that therapeutic communication, and get them to the hospital that is a stroke center certified facility. Okay, hemorrhagic strokes are a little different. They're right around about 13% of most strokes. And this results from bleeding that is inside the actual brain tissue. It can also be on the outskirts of the brain tissue, but either way, the blood is coming into contact with brain tissue. Okay, and remember that blood is acidic, and our tissues do not like acidic stuff. Okay, cerebral hemorrhages are often fatal. And to be honest with you, I've seen a couple of hemorrhagic strokes in my time. And unfortunately, and I don't, I'm not trying to impress upon you guys any of my thoughts, but, I've seen people survive hemorrhagic strokes, and their quality of life is very poor, Me personally, if I ever suffer a hemorrhagic stroke, I hope to God that I just die, right? Because it could be very debilitating if people survive it, but most of the time, this is a fatal blow when it comes down to it. People that are at high risk usually are people that are extremely stressed out, people with a history of chronic high blood pressure, and physical exertion. That they just kind of overly exerted themselves. And again, but the people that are most at risk for a hemorrhagic stroke is people that have uncontrollable high blood pressure. So basically, the other term for hemorrhagic stroke is an aneurysm. And we talked about this already in cardiac a little bit, but remember, an aneurysm is actually a defect in the arterial wall, usually due to chronic high blood pressure, where it actually has a defect or the weakening of the arterial wall, and the actual aneurysm keeps growing and growing and growing until eventually it pops. And again, when we're talking about hemorrhagic stroke, specifically with cerebral aneurysms, these are the people that just drop dead. They're walking, they're talking, boom, they're dead. Something just pops in their snot deep in their bowl of Cheerios or whatnot. Okay, not much that we can do for this, guys. Right? Even on the surgical table, if they happen to do a craniotomy on you and they see this happen, more than likely they might not even be able to save you then. But we are still going to deal with the symptoms. Remember, we're going to treat the patient, not the numbers. We're going to treat the signs and symptoms and not the numbers. And we're still going to try to do our best in order to help this patient out. So again, the big symptom is a very sudden onset of a severe headache. And these people, once again, will describe this as the worst headache of their life, or possibly never having experienced anything like this before. When hemorrhagic strokes in young people, they're called berry aneurysms. Berry aneurysms, I kind of threw in this lecture because we've had rumors that a berry aneurysm has been showing up on the National Registry exam as possible one of your questions. A berry aneurysm is basically a very small aneurysm where the actual blood vessel kind of popped out a little bit, and it just kind of pops, but it's small enough to actually close back up. And there is possibilities that they may need surgical repair, and we need to make sure that that care is recognized, and that we transport these patients immediately. So if you guys see Berry aneurysm, all they're talking about is basically a very small hemorrhagic stroke. I know that sounds silly because now I'm trying to characterize a hemorrhagic stroke. Let's put it. Not gonna bullshit you guys. A hemorrhagic stroke's bad. I don't care if it's an aneurysm. I don't care if it's a Berry aneurysm. If you are bleeding in your skull, this is a medical emergency. Okay. Either way, we're still going to provide the same treatment. Just know that that term is out there. All right. Things we can't do anything about when it comes to strokes: our age. We're all getting older, right? We're all gonna die. Death and taxes, two most guaranteed things in life, right? Your heredity, family history, possibly your race. Some races are more prone to blood clotting than others. Your sex, we've already talked about that, right? Males suffer more strokes than females. However, females have more fatal strokes than males. So it's kind of a give or take. And things that can't be controlled is if they've had a history of prior strokes, they could have another stroke again. There's also something called a TIA. It's also known as a trans ischemic attack. We're going to talk about that here in a sec. Trans ischemic attack is basically a mini stroke, what we call a mini stroke. Think of it as kind of like angina to the heart attack. A TIA is the precursor for a possible CVA to follow, right? So patients can have these little TIAs over and over and over again. And the TIA can actually resolve itself, basically. They have this little stroke. Grandma's just confused for a couple hours, and all of a sudden she comes right back to, and everything's good. She more than likely had a TIA. TIAs are medical emergencies, guys, okay? Just like angina is with cardiac. We need to get these patients to the hospital. They need to do a CT scan of the brain to see if they can alert the patient that, hey, there's stuff going on in your head. We're going to put you on a treatment plan. And you could have a stroke, a very big stroke coming anytime now. And again, that TIA, the trans ischemic attack, that's what it means. Trans ischemic attack is really the precursor for a big stroke. Heart attacks, history of heart attacks, people, your risk of stroke goes up as well, and any other kind of arterial diseases, such as the atherosclerosis or the arteriosclerosis, or maybe they already have a history of a head injury, and they have problems with the functions of the constriction and the dilations of their vessels in the first place. So there are quite a few different things as far as risk factors that we have no control over. Which leads us to what can we control? Well, the big thing that we can control is our diet. We want to make sure that we do not have high cholesterol in our diet. There's good and bad cholesterol. We want more good than bad cholesterol. That's a simple blood test, right? High blood pressure. Okay. If we know somebody that has high blood pressure, we need to make sure that they're taking their medications accordingly, that they're watching their salt intake. Again, coming back to diet, making sure that they're drinking plenty of water. Cigarette smoking, and cigarette smoking with use of oral contraceptives, specifically our females. You females that are on birth control and smoking at the same time, man, you guys are like 1,000 times more susceptible to stroke than even somebody with a stroke history. So make sure that you guys aren't using your birth control and smoking at the same time. That's just a dangerous combination right there. Anybody with diabetes. Diabetes is an awful disease process. It's definitely something that you guys do not want to experience in your life. And again, this kind of comes down to diet and exercise. Unfortunately, some of us are born with diabetes, and we have to control our diabetes that way. And there's diabetics out there that take very good care of themselves. and they watch what they eat, and they're on specific diets, and they take their insulin when they're supposed to in order to help regulate their sugars. And we'll talk about that more when we get into endocrine emergencies. Atrial fibrillation is a heart rhythm that's kind of, you guys have heard of ventricular fibrillation, and that's where the ventricles are kind of just sitting there quivering. Well, the atrials can do the exact same thing. And the problem with the atria not contracting the way that they're supposed to is they're not too muscular to begin with. And we actually really kind of let gravity kind of do its thing to help us get that atrial kick. Hopefully you guys remember that term, where we're waiting for those atria to actually drop all the blood into the ventricles before the ventricles start to squeeze. But with atrial fibrillation, that blood is becoming stagnant, right? So we're not really getting all the blood out of our atria that we're supposed to be for that, what's called that atrial kick. So again, when blood pools, it coagulates, okay? So if the blood is hindered from circulation in our body, it's going to start to form clots. And people with atrial fibrillations do have or are more susceptible to clotting disorders or clotting factors, increasing their chance of actually developing a clot. Sickle cell disease is mostly found in our African American friends. It's a disease process that is specific to them. There are some other ethnicities. I believe some of the Greeks, Mediterranean kind of ethnicities can also have sickle cell, but it's mostly found in our African American population. We're going to talk about sickle cell later on this semester. Poor diets and no physical activity and obesity. Those are all things that can be controlled or treated or changed. Lifestyle changes, right? And again, we can do everything for our patients. And if they're not willing to change, we're going to run on them again and again and again and again. And there's going to be certain people that you guys meet in EMS where you guys run on them numerous times and watch them die because they do not want to be compliant with their medical treatments, or they just have some kind of disease process that unfortunately is killing them faster than they want to be killed. So keep that in mind, but these are the risk factors that can be changed, treated, or controlled. Okay, as promised, TIAs, they're transient ischemic attacks. This is when blood flow to the brain is obstructed due to more than likely the atherosclerosis or a small blood clot, and the patient may exhibit the signs and symptoms of an actual stroke. The actual stroke-like symptoms will go away on their own, usually less than 24 hours. If those signs and symptoms of the stroke go away before 24 hours, it's known as a transient ischemic attack. And there's really no tissue damage when it comes down to it. That's why the patient actually kind of returns to normal. However, once again, remember that the TIA is the precursor to the CVA. The TIA is kind of like the warning sign saying, hey, something needs to be done. We need to change something really quick or we're going to have a really big stroke. So the symptoms with the TIA usually can last up to 24 hours. And because of this, we might not be able to differentiate between the CVA and a TIA, right? And really, when it comes down to it, who cares? Okay, we have somebody with altered mentation. They're not acting right. They might be complaining of some sort of paralysis. We need to get this patient to the hospital. They need a CT scan to see if they are eligible for thrombolytic therapy, okay? It's not us to decide if this is a TIA or CVA. It's not us to decide if this is an ischemic stroke or hemorrhagic stroke. Who cares? I have a patient with altered mentation and they're complaining of facial paralysis or something like that. It is a stroke until proven otherwise, right? And any doctor out there, any certified stroke facility would much rather have you guys call a stroke alert and be wrong than call a stroke alert than not call the stroke alert and be wrong about that. Okay, if you guys are in doubt about this, just call the stroke alert. All right, you guys are acting in the best interest of the patient. The the ER is not going to give you crap for this, right? In order to be a stroke certified center, they have to be pretty proficient at finding the strokes in a reasonable amount of time. And you guys, EMS in general, is the number one helper of the actual stroke centers for us being able to recognize the signs and symptoms and calling in the stroke alerts to the receiving facilities. And again, this could be a warning sign that more significant stroke may occur in the future, and all patients that are having TIAs should definitely be evaluated by a physician. Okay? Really, the difference between the TIA and the CVA is that the TIA, there is no lasting deficits after 24 hours. And again, remember that when we're dealing with strokes, we won't be able to tell the difference between a TIA or a CVA, and we only really have, that patient only really has a certain amount of time frame, a window, in order to be eligible for thrombolytic therapy. So we want to make sure that we're advocating for our patients and getting them to the quickest, most appropriate facility that's going to fit their needs.